everyone. I'm Lieutenant Candace Marshall-Humphrey. I'm one of the lead public health analysts in the Office on Women's Health, and it is my pleasure to welcome you all to our seminar series for National Eating Disorders Awareness Week. Eating disorders affects Americans of all ages, racial ethnic backgrounds, gender orientations, body shapes, weights, and socioeconomic statuses. And so one of the importance of us coming here today is to really talk about, eating disorders and the fact that there is no one look to eating disorders, but then also talk about ways to better screen and treat and get those most impacted into treatment as soon as possible. So for those of you not familiar with the Office on Women's Health, I'll just tell you a little bit about the office. So we are located in the Office of the Assistant Secretary for Health. And we do have some priorities around eating disorders. Most recently in the Office on Women's Health, we announced 2 community grants focused on eating disorders among adolescent girls. The 2 recipients are Washington University in St. Louis, Missouri, and George Mason University in Fairfax, Virginia. And of course, we are contributing and partnering with National Eating Disorders Awareness Week to really continue the conversation. So as we focus on our theme, CARE, which is continue the conversation, act early, strengthen recovery, and end the cycle. As a part of that, we know, again, that screening, treatment, and then supportive services are so important to a recovery for eating disorders. And so I'm going to introduce Dr. Peat, our speaker, who's going to share more about the expert screening tool. So Dr. Peat is Associate Professor of Psychiatry and the Center of Excellence for Eating Disorders, which we all call NCEED at the University of North Carolina at Chapel Hill. In her position as director, she broadly disseminates education and training on eating disorders, specifically for providers across a variety of disciplines. And her research really focuses on the pathology of eating disorders with an emphasis on binge eating disorder. So she's a licensed psychologist in North Carolina. And today she's going to share with us NCEED's new platform that they created called SBIRT-ED. So it's a tool that can help providers easily screen, treat, and again, get their patients into treatment and then supportive services within their local communities. So without further ado, I will turn things over to Dr. Peat.
Thanks everybody for joining us here this afternoon or this morning, depending on where you are in the country. We really appreciate your time. As Candace mentioned, I am the director of the National Center of Excellence for Eating Disorders, an associate professor of psychiatry here at the University of North Carolina at Chapel Hill. And I really am excited to talk to you all about eating disorder diagnosis and referral, particularly in a primary care setting. I recognize that folks that are here today may be coming from all sorts of practice settings, but I'm hoping that what we talk about here today will have utility no matter where you practice, even knowing that there is a general focus here on the primary care setting. We are funded, of course, through SAMHSA, so this is my funding statement. And for those of you who are not familiar with us as an organization, the National Center of Excellence for Eating Disorders is the nation's first and only federally funded TA center dedicated to eating disorders. We were founded through a grant mechanism in 2018 through SAMHSA, and we have been really thrilled to be at the helm of this work and really trying to upskill the provider workforce in terms of giving them the knowledge and the skills that they need to detect and manage eating disorders in clinical practice. Our overall mission is to advance education and training of all kinds of healthcare providers, whether you're a physician, a nurse, a psychologist like me, folks who work in school settings, for example, to really promote public awareness of eating disorders and also their treatment. And our ultimate goal is to ensure that all individuals with eating disorders are identified, treated, and supported in recovery. We know that this is not something that we can do alone as specialty providers. We really need everyone to be involved. So we're thankful that you're spending part of your day here with us. In terms of what we offer here, bear with me just one moment. I am a little bit out of order. There we go. All right. In terms of what we offer here at the center, and I provided our hyperlink here on the bottom right-hand corner. And these slides, I do believe, will be shared. So you'll have access to all of these hyperlinks and you won't need to take copious notes during today's presentation. But our website gives everyone sort of access to aggregated, vetted, evidence-based resources that are really focused on healthcare providers. You can search for your particular discipline to find resources that are specific to your scope of practice. And we've made all of this available online for free so that it's this sort of scalable, adaptable technical assistance approach that really helps to kind of evolve as your practice evolves. So we're hoping that the information we provide is kind of available at your fingertips when you need it. So that's a little bit about us and the center and the work that we do. But I do want to jump in and talk a little bit more about eating disorders, the diagnoses, kind of what we're talking about, so that we're all on the same page when we think about these conditions and who they affect. So I'm not going to go into a ton of detail about all the specific diagnostic criteria because I think that's actually a little bit out of scope of what is most relevant here for this presentation. But I wanted to at least highlight the eating disorder diagnoses that we think about in practice and what you all can be thinking about through the course of this presentation. So I have intentionally started with a diagnosis that some of you may actually be unfamiliar with, something called other specified feeding and eating disorder, or what we call OSFED. And I started with this diagnosis because it's actually the most common eating disorder diagnosis. I know that there are other ones that you likely have heard about either in your training or in pop culture, but this kind of OSFED diagnosis is actually the most common presentation, particularly in a primary care setting. So we think about these folks as individuals that are engaging in some sort of disordered eating practice, disordered eating thoughts. So these might be folks that are engaging in binge eating behaviors, maybe they're engaging in risky dieting behaviors, but they don't kind of fit neatly into any of the other categories that currently exist. And so really, when we think about a primary care setting, it's going to be unusual for folks to come in and meeting full threshold criteria for, let's say, bulimia nervosa. It's much more likely that they're going to have a handful of symptoms from one diagnosis, a handful of symptoms from another, and you might think about these folks as having OSFED, for example. One of the other diagnoses that you're very likely to see in a primary care or generalist setting is something called binge eating disorder. So binge eating disorder's defining feature is eating an unusually large amount of food accompanied by a sense of loss of control. So when you hear the term binge eating, I think oftentimes we think about individuals who might be eating large volumes of food in one sitting, but that's really not the hallmark. The hallmark of a binge eating episode is that sense of being out of control. I cannot stop eating once I start. Even if I wanted to stop, I feel like I can't. And so individuals with this particular diagnosis will have these recurrent episodes of binge eating where they feel out of control, then they feel guilty, ashamed, disgusted with themselves. And there's a significant kind of cognitive and emotional burden that comes with this diagnosis. Another one that you are all likely familiar with is anorexia nervosa. And the defining feature of this diagnosis is an intense fear of gaining weight and a restriction of energy intake or of food that leads to a significantly lower than expected body weight. In previous versions of our diagnostic classification, you had to meet a certain threshold in terms of being low weight. But in the revision, they've sort of given us a little bit more leeway. So again, with anorexia nervosa, the defining feature here is not someone's weight status. It is not about being exactly a BMI of 16, for example. The defining fear is really this cognitive component of intense fear of gaining weight, such that you end up restricting your food to the point where you end up losing really significant amounts of weight. And some of those individuals may actually end up being clinically underweight. One thing I do want to draw your attention to, however, is a diagnosis called atypical anorexia nervosa, which is what we really think about as sort of anorexia nervosa in higher weight bodies. So these are individuals that have that exact same kind of defining feature of being really afraid of gaining weight. They might only be eating 500-600 calories per day, but these are individuals that may not necessarily get to a low BMI. These might be folks that are hanging out in BMIs with 25, 30, for example, but they've had really precipitous weight loss. They might have lost 30, 40, 50 pounds in just a few months' time. But these folks are likely to fly under the radar because they're more likely to be congratulated for their weight loss versus being detected or screened for an eating disorder. One of the other diagnoses that I'm sure most of you are familiar with is bulimia nervosa. The defining feature here is having those same recurrent binge eating episodes that we talked about in binge eating disorder, but then they're sort of paired with these inappropriate compensatory behaviors. So that might be things like self-induced vomiting, abuse of laxatives or diuretics, driven or compulsive exercise. The idea is that these folks have those out of control eating episodes or those binge eating episodes. And then in an effort to make up for those binges, they might do something like engage in self-induced vomiting or engage in really driven or compulsive exercise. One of the other diagnoses that is a little bit newer and a lot of folks are not as familiar with is something called avoidant restrictive food intake disorder, or ARFID. And this is a diagnosis that's really defined by a failure to meet appropriate nutritional needs. And I do want to say that although it sounds a little bit like anorexia nervosa, you'll see that the defining feature here is not that cognitive component of being fearful of your weight or of weight gain, but it's this pervasive and persistent failure to meet your nutritional needs, such that some individuals will actually be underweight. They're certainly malnourished. But for many times, in many situations with folks with ARFID, these are people that are having trouble meeting their nutritional needs because they have a hard time with the sensory characteristics associated with food. Or maybe they've had aversive experiences when eating. So maybe they had a choking accident or really bad GI distress. And it's those things that are leading people to not meet their nutritional needs versus the fear of weight gain, as you might see in anorexia nervosa. So those are really the primary eating disorder diagnoses that we think about in a specialty setting. And what I'd like you to have in the back of your mind as we're discussing the eating disorders during today's presentation. But one thing I do want to make crystal clear, especially during National Eating Disorders Awareness Week, is that eating disorders do not discriminate. Unfortunately, there are a lot of really old stereotypes out there about who is affected by eating disorders, what they might look like. But in contrast to that stereotype of the thin, cisgendered white woman, in reality, people with eating disorders are going to look like the folks here on your screen. They're going to look like the patients in your clinic, your neighbors, folks in your community. There is no one look to having an eating disorder. And part of the part of the reason that we are so passionate about making sure that this is part of our presentations is to make sure that we're widening the net of who we're screening for eating disorders. It's not just the folks that are underweight. It's not just the folks who are telling you that they frankly have concerns about their eating habits or their body weight or shape, because many individuals with eating disorders are actually going to appear quite healthy. They may actually seem asymptomatic, which is part of why it's so important to do more regular or routine screening. In fact, we know that for many individuals who are part of marginalized groups, you're less likely to be detected with an eating disorder, even though may be more at risk for developing some of those symptoms. So the data that you see here were pulled from a study looking at binge eating disorder in particular among racial and ethnic minorities. This was pulled from a community sample, so not treatment-seeking folks. And what they found is that binge eating disorder prevalence was actually higher among Latina and African American women in comparison to their Caucasian counterparts. And among treatment-seeking samples, as many as a third of those individuals may actually be African American women. So I think it's important to highlight this idea that even though it may not be part of the stereotype of eating disorders, individuals who come from marginalized populations may actually be at greater risk for the development of certain forms of eating pathology. In addition to that, we also know that our transgender communities are individuals that often struggle with eating pathology. Sometimes this goes hand in hand with the gender dysphoria that happens, particularly among our trans teens and young adults. So as they're moving into puberty or getting closer to puberty, they may be engaging in eating disorder behaviors as a way of suppressing secondary sexual characteristics that just make that gender dysphoria even worse. But that, of course, doesn't mean that these two things often, that they always have to go hand in hand. There are some individuals that even after receiving gender affirming care may continue to struggle with an eating disorder. So I think it's important to just have these folks on your radar, knowing that they're just at an increased risk for the development of these conditions. So with all of that said, why do eating disorders matter? Why are we taking an entire presentation to talk about this? Why did the White House give a proclamation on Eating Disorder Awareness Week? Some of this has to do with the prevalence. These data were pulled from a report that came out in June of 2020 in collaboration with Deloitte Economics and a couple of eating disorder organizations. And what this report found was that roughly 28 million Americans will have an eating disorder at some point in their lifetime. So we're talking about roughly 9% of the US population. And that's a number that I think is much higher than people typically think about when we think about who is affected by eating disorders. And unfortunately, these are conditions that we know are life-threatening. Roughly 10,000 people will die every year as a direct result from their eating disorder. Many of these individuals may die by suicide. In fact, it's estimated that one person will die every 52 minutes as a result of their eating disorder, meaning that at least one person will lose their life during the course of today's presentation. And in addition to the number of folks that are affected by these conditions, I do think it's important to highlight that there's a high case fatality rate for eating disorders. The mortality rate for eating disorders is really second only to opioid use disorder when it comes to mental health conditions. And that's a fact that many people are surprised by, knowing that these are conditions that oftentimes go overlooked. I mentioned briefly that there is an increased risk for suicide with eating disorders, particularly among college students, who we know are 11 times more likely to attempt suicide than their peers who don't have eating disorders. And there's also a growing body of literature that's come out in the last several years looking at food insecurity as a particular risk factor for eating disorders. So again, sort of pushing back against those stereotypes about who struggles with these conditions. We know that people that are having a hard time keeping food in their households are individuals that are also more likely to be engaging in things like self-induced vomiting, abusive laxatives, binge eating, these kinds of hallmarks of bulimia nervosa. So again, in as much as your clinical practice may be interacting with folks that kind of fit some of these descriptions, I think it's important to keep eating disorders on your radar as a possible differential diagnosis or a possible comorbid diagnosis. One of the other things I like to highlight in the course of these presentations is just the overall impact that eating disorders have on daily life. I think that, again, one of those stereotypes that we have are that eating disorders just affect your relationship with food or just affect your relationship with your body. But there was a survey done by the World Health Organization several years ago looking at the level of impairment that people are experiencing due to their illness status. And in this situation, they zeroed in specifically on binge eating disorder. And so what you're seeing here are data from that survey looking at the degree of impairment that people with binge eating disorder had in a number of different life domains. So whether that's in their work life, their home life, their social life, or in their close relationships. And what you can see is that for folks with binge eating disorder, 38% of these individuals were reporting some degree of impairment in their social life, with 8% reporting really severe impairment. And if you look at across these different domains, almost half of the sample were reporting some degree of impairment in any of these really important life domains, with roughly 13% reporting severe impairment. So again, I think it's just important to highlight that eating disorders are not just about food, not just about the body. These are conditions that can really take over your life and create really significant impairment in important life domains. Above and beyond that, we also know that eating disorders take an enormous toll on the healthcare system. So the same Deloitte economics report that came out in 2020 was looking at the economic impact of eating disorders. And they found that eating disorders cost the US economy somewhere around $4.6 billion just in eating disorder treatment costs. Some of those actually come from the highest levels of care, which you can see on your right-hand side of the screen. Roughly $107 million is spent annually just on hospitalizations for these conditions. So we know that treatment can really be expensive. In addition to that, they also were looking at the greater impact on society, the workforce, and businesses when it comes to eating disorders. And they estimated that roughly $48 billion are lost every year associated with eating disorders. That might be things like caregiver loss of time, if they're needing to take time off of work to care for a sick loved one or for a child. If it's an adult that's needing treatment and they're needing to come out of the workforce to receive treatment at a higher level of care, these are all associated impacts that might have on the economy. So all told, if you add up the treatment costs and the other impacts to society and our economy, the Deloitte economics report found that eating disorders cost the economy roughly $64 billion per year. So these are conditions that we know are common, they're life-threatening, and they're really costly to the American economy and to the American public. We also have reason to believe that the pandemic has worsened eating disorders, and we've seen that play out in a couple of different ways. So there have been higher caseloads since the pandemic, roughly 2 to 3 times higher than they were in the pandemic, prior to the pandemic, which you can see here in some of the data from a children's hospital in Boston that are also mirrored at another children's hospital in Ann Arbor. And one of the things I'll say is that unfortunately, these numbers don't seem to be coming down. They may have come down slightly from their initial sort of peak at the earliest part of the pandemic, but they have not returned to the levels that they were prior to the pandemic, which I think is just really troubling and part of the reason that we need lots of folks to be involved in these efforts when it comes to care. There have been a number of reasons that have been sort of thrown out there as to why the pandemic may have worsened eating disorders, particularly for children and adolescents. And I would be remiss if I didn't highlight the potential role of social media when it comes to eating disorders, given that we know that children and adolescents are particularly vulnerable to the really predatory algorithms that exist in social media algorithms. So there has been a growing body of research looking at how social media sites and online sources can actually actively encourage eating disorder behaviors, whether that's pro eating disorder content, whether it's having non-healthcare providers give advice about dieting and weight loss. And unfortunately, these kinds of avenues are widely accessible to children and adolescents, and it can exacerbate the existing presence of an eating disorder or even trigger a non-existing one prior to their exposure to this kind of social media. So I think it's important to keep in mind that this is a vulnerable population and that role of social media may have actually been a bigger player in this part of the landscape than maybe we'd appreciated before. So knowing that, we really do think about eating disorders as a public health concern. But with that said, there's a number of different challenges. So even though we know that these are common and life-threatening illnesses, at best, maybe 50% of those with an eating disorder are ever going to receive treatment. And it's even less so if you come from one of those marginalized communities that we talked about. If there is care available, it's often incredibly costly, as we talked about at the beginning of the presentation, and it's often only available in major metropolitan areas. So if you live in rural parts of the state, like much of our country is, you may have to travel long distances for many hours to get to a treatment center, which really makes it hard for folks to sustain that treatment if they're having to go multiple times a week, for example. And then above and beyond all of that, we know that most healthcare providers aren't trained in eating disorders. And that's not because I think it's an intended sort of omission or an intentional sort of turning a blind eye to this content area, but just knowing that, physicians, nurses, psychologists, there's so many areas that we have to be trained in. And I think for a long time, we thought that eating disorders weren't necessarily a priority because they weren't happening to a great number of people. But I think that with the newer data that are coming out, it's really going to help to sort of turn that paradigm so that eating disorders become a much more common part of that training. And that's a little bit of where we come in as well at the National Center of Excellence for Eating Disorders. With those challenges, we know that there are a number of consequences. So first and foremost, if folks aren't receiving care, if healthcare providers don't know how to screen for these conditions, there just tends to be an overall lack of detection. And with that, the longer someone goes without a diagnosis, the longer it may be before they're into treatment. So typically there's a poorer prognosis, as there tends to be with most physical and mental health conditions. We also know that folks with eating disorders tend to be high health service utilizers. These are folks that are going to be going regularly to the primary care doc or regularly to the emergency department. So in as much as those types of care are really inundated with regular requests, we know that eating disorder folks tend to be high utilizers of these services. And then with all of these consequences collectively, we know that this can lead to a prolonged illness and sometimes some of that morbidity and mortality that we talked about. So really, there's a lot of room for improvement in the eating disorder landscape. And that's part of why we're so thankful that you're here at today's presentation so that you can walk away with really tangible information and how you might use that in your clinical practice. So with all of that information, you might find yourself thinking, what can I do as a healthcare provider, knowing that these are common illnesses, that they often go undetected, that there can be really negative outcomes for my patients who might be struggling with this form of eating pathology? And one of the things that we would encourage you to do is to screen your patients. This is something that is sort of that first step in catching people in the earliest part of that pipeline. And that's part of what we'd like to share with you today is a specific strategy that the National Center of Excellence developed to help you be able to screen your patients, particularly in a primary care setting, and get them referred to the specialty care that they might need. A little bit of background about this approach. Many of you may actually be familiar with the framework, which is referred to as screening, brief intervention, and referral to treatment. This is a well-known public health harm reduction approach that was actually developed, again, for primary care providers, but specifically when it came to substance use disorders, more specifically alcohol use disorder. So this SBIRT approach was initially developed so that primary care clinicians could screen folks for a possible alcohol use disorder, do some brief intervention during the visit, and then get these folks referred to specialty care if it was indicated. So knowing that this is something that has had decades of research behind it, knowing that it's an evidence-based approach, we here at NCEED felt like it made sense to take that same approach, but simply swap out the content. So instead of it focusing on substance use disorders, we're instead making it relevant for eating disorders. So that's exactly what we did. We worked with a number of our primary care colleagues, knowing that NCEED is not primarily made of those folks. We wanted to make sure that that stakeholder group was really in with us from the ground up, to make sure that we were developing something that was relevant for their scope of practice, was going to be functional and easy to use, knowing that PCPs have so much to manage in a relatively short amount of time. And so what I'm going to walk you through in the next couple of screens is essentially what we developed. And so we're hoping that this will be a tool that, again, will help address some of those challenges that we discussed just a couple slides ago, and really help to increase the awareness of eating disorders in a busy primary care setting. So SBIRT for Eating Disorders is an easy to use online screening tool specifically for healthcare providers. I'm actually going to do a brief demo here in a moment so you can see what it looks like, but this gives you a screenshot of our homepage. And the interesting thing here is that when we did the initial development, we really thought that we were going to create like a standalone app. But one of the first pieces of feedback that we got from our primary care colleagues was that they were not going to download another app to use or another thing that they had to keep track of during the course of a visit. If this couldn't be in the EMR, which for feasibility purposes, initially we couldn't build it in that way, then they wanted it just as a quick, freely available, easily accessible website, which is exactly what we did. And what we then provided them with was an evidence-based screening tool that's already been validated for use in adults in a primary care setting. And so we've given them access to that on the left-hand side of the screen there, the screening tool that gives them quick and free access to a validated tool. And then essentially after just a couple of clicks, the provider is told whether or not their patient is at risk for an eating disorder. So did your patient screen positive, yes or no? If the answer is yes, what level of risk are they at? Are they at a low risk for an eating disorder, medium risk, or high risk? And that really mirrors what kind of exists in the substance use world. Is this person at low risk for alcohol use disorder, high risk, those sorts of things? We've then moved on to the brief intervention component, where our primary care colleagues said, listen, we're fine with screening. This is something we're really comfortable with. We know how to do this in primary care, but I don't know what to say if a patient screens positive. I don't know how to have this conversation without maybe triggering my patient or making them feel worse. So we've developed a series of scripted prompts or conversation snippets to help the clinician guide discussion on why they're concerned about an eating disorder for this particular patient. And then that last piece, the referral to treatment piece, comes up in the referral to treatment step-by-step guide that we developed. And this is something that could be printed off and handed to a patient. It could be sent digitally through the electronic medical record. And it gives both the clinician and the patient access to a nationwide free searchable database for eating disorder treatment based on your geographic location, based on your insurance status. And so this allows a clinician to help link a patient with that kind of specialty care, no matter where they might be in the country. The last piece is on the right-hand side here, a list of different patient resources, again, based on feedback from our colleagues who said, all of this is great, this is just what I'm looking for, but I also like for my patients to have some resources in their back pocket, just in case they're needing something more tangible while they're waiting to get into a specialty visit. So we've created a curated list of different self-help resources, free online support groups, so that all of that is available in the protocol. So that being said, I do want to do a quick demo, and I'm just going to quickly switch over screens. So what you should be looking at here is the website. This is the Screening for Eating Disorders website, and this is our homepage. You can just click on Get Started. These are the 5 questions that come from a validated measure called the SCOFF. And just for argument's sake, I'm just going to say yes to all of these so that you can see how this works in practice. Some legalese you just say yes to, click Continue. And basically what you're told is after those couple of clicks that your patient had a positive screen for an eating disorder and their risk level is high because they said yes to all of those. This text here was actually developed by some of our primary care colleagues who said, if I screen for something, I need to say that I did that. I need to say what I did in response to that positive screen, and then what the plan is for follow-up. So we've created this language here, and you can click this button and you can copy and paste that directly into your note in your EMR. Below that are those scripted prompts that I mentioned. So here's a way to express your concern about the symptoms that your patient said yes to. So I'm concerned that the symptoms that you're reporting are actually signs of an eating disorder, and these are actually very common eating disorder symptoms. And I'm concerned that these are going to get worse if you don't get specialty treatment, right? So this is how you then would discuss next steps. This isn't meant to be read as a script verbatim, but it gives you a place to start. And then lastly, this is that step-by-step referral guide that I had mentioned from before, where this could be sent to a patient electronically or printed off to a patient. This is the link to that free searchable database, tells you how to use it, and also helps a patient understand what they're supposed to be doing in that specialty visit. If I call there, what do I say to the receptionist? If I go to this visit, what should I expect? What should I bring with me? We tried to take a lot of this guesswork out of the process so that folks would be more comfortable with the referral process. I'll go back briefly just to show you quickly the patient resources that we developed. So there are some self-help resources that have again been validated in the research literature, a specific resource for parents and caregivers, some of the online support groups that exist as well. And then we've made the step-by-step referral guide and our insurance toolkit available here in the resources section, both in English and in Spanish. So with all of that said, let me just go back to my slides here. That is just a very brief demo of SBIRT for eating disorders. And so with that in mind, if you are using this in clinic, I wanted to give you a couple of pointers. So first and foremost, if you are going to be referring to a specialty center, make sure that you're prepared for a couple of things. Number one, not everybody is super gung-ho about getting referred to specialty services, as I'm sure many of you are aware of. So there may be some reluctance or some ambivalence about this referral. So we encourage you to follow up with your patient at the next visit. Hey, I mentioned in your last visit being concerned about you binge eating on a regular basis. Did you follow up on that referral? Have you run into any problems with that? And also keeping in mind that eating disorders care is really limited at this time and it's hard to access. So just be prepared for needing to be a little bit patient with this process and helping your patients navigate to the extent that you can. When it comes to the levels of care, I'm not going to spend a lot of time talking about this in the interest of time, but just know that when it comes to treatment, there's all kinds of different levels. Everything from the lowest level, like outpatient, patients are being seen roughly once a week, all the way through inpatient hospitalization, like we have here at UNC, where folks are actually admitted to the hospital. That's not a decision that you have to make alone in terms of the level of care. You would do that in collaboration with the specialty practice. But suffice it to say, this is really driven on patients' current symptoms, how severe they are, how frequent, those sorts of things. When it comes to the challenges associated with these different levels of care, I think it's important that you also know that there can be some resistance from parents or from patients, especially if we're talking about inpatient hospitalization. No one wants to go to the hospital, right? So I think I would be remiss if I weren't preparing you for some of that pushback with some of your patients. If these are children or adolescents, sometimes folks are concerned about school schedules, knowing that eating disorder care is not always available in every state. Sometimes it means coordinating out of state care, which can be challenging in and of itself. Again, we know that there's a long wait list for bed availability. Again, these are specific for higher levels of care, but also to some extent for outpatient care as well. And then with insurance coverage, it's a different carve out than it is for their medical benefits. So I think a lot of patients really need some upskilling when it comes to how to use their mental health benefits, which is part of why we created that insurance toolkit for them to use. And then unfortunately, many providers can just simply check a box and say that they treat eating disorders, even though they're not actually engaging in evidence-based practice, which is why we've done our homework here at NCEED and really tried to link you up with providers in that searchable database that we know have been vetted in some way and that they're doing good care for these conditions. So when it comes to being in a primary care setting, how do you coordinate care? What is it that you're doing outside of screening? So I mentioned obviously pretty at length about the importance of screening and doing some of this initial detection, and then of course making that referral. But one of the other major pieces I want to highlight is that you as a clinician can really help to enhance motivation for patients to follow through with that referral. You can express concern about the medical symptoms that you're seeing. So for example, if you know somebody is making themselves throw up on a regular basis, you can talk to them about how that's dangerous for their health because many people actually don't know. Or if you're seeing that somebody has lost really precipitous amounts of weight, you can help them understand the dangers of that, the malnutrition, what can happen to their bodies. Because many times, if they're hearing that from a trusted medical professional, it may help to increase their motivation to seek that sort of care. And then additionally, making sure that you're continuing to treat the ongoing comorbidities. So if a patient is, getting a prescription from you for an anxiety disorder, or maybe you're continuing to manage their hypertension, those are the sorts of things that many eating disorder clinics are going to want to know or under good medical management before accepting them to a higher level of care, for example. So with that being said, I want to make sure that we do leave some time for questions that are coming in, but I have created, or our team has created some toolkit pieces that might be helpful for you as you're navigating this process. You can scan these QR codes. Again, you'll get these slides, so you'll have access to that down the road. If you're interested in learning more or staying tuned to the work of what we do here in the National Center of Excellence for Eating Disorders, you can sign up for our newsletter and for our education calendar. The newsletter comes out 4 times a year, so we promise not to inundate your inbox, but it's a way to keep up with our goings on and to keep you abreast of any new information or new products that we might have developed here. So with that being said, I want to leave you with my email address. You are welcome to be in touch with me directly if there are questions that have come up during the course of this presentation. And I, again, just want to take this opportunity to say thank you for your attention, for coming today and being willing to engage in this discussion and hopefully fold some of this into your work and a clinical practice. Thanks so much. I'll turn things over to Linda now.
So thanks everyone for being here. We have so many people here today. What I think we're going to do is have you write your questions in the text in the question and answer box. And I'm going to start there now and give everyone some time to think of them. So the first question was, can we get copies of the slides? And Dr. Peat, you said that's fine. What we'll do is we'll take the slides and put them on our National Eating Disorders Awareness Week website, which I'll put the link in for everyone in just a moment. And we'll also have the recorded portion of this there as well. So if you got here a little late or you just thought, gosh, I want to go back and hear what Dr. Peat had to say again, you'll be able to do that on our website. So our next question, Dr. Peat, is can OSPED also apply to infants who need to have feeding tubes?
Yeah, that's a great question. So when it comes to infants, typically we're not thinking about an eating disorder diagnosis because eating disorders are mental health disorders. And so there has to be sort of this cognitive component or this impairment component that I think is really hard to nail down with itty bitty babies. So I think it's important to note that infants and children can struggle with feeding disorders that don't necessarily classify as eating disorders. But again, I think that it's a good place to start with the pediatrician, kind of assess what's going on, make a referral from there. Many university-based systems have pediatric feeding clinics that can do some of that initial kind of evaluation. And if they're not seeing anything concerning in that way, then you might eventually end up in an eating disorder clinic. But I would say that's going to be more common for older children and less so for infants. Great question.
Okay. Wonderful. And next question is it common for those with bulimia nervosa to also have the AFRED as a result?
Yeah, that's another great question. So technically, when it comes to diagnosis, you can only meet for one diagnosis at a time. So you can either have bulimia nervosa in this cross-section of time or ARFID. That being said, we know that over the course of someone's lifetime, there tends to be a lot of what we call diagnostic crossover. Lots of people may start with one diagnosis, and over the course of their illness, maybe they shift from bulimia nervosa to binge eating disorder, then maybe to atypical anorexia nervosa, for example. So your question is a good one in that although you can't have 2 diagnoses at the same time, you may have 2 or 3 diagnoses over the course of a lifetime, if that makes sense.
Okay, next question, is there any data related to Native American populations? Any particular tribal communities that may suffer more than other tribal communities? Any data on that?
Lovely question. If there are data, they're scant, and at this point, they're probably outdated, unfortunately. I don't know that we have really good prevalence estimates for our Indigenous folks, for our Native American folks. I will say, just as a brief aside, the National Center of Excellence for Eating Disorders really sees this as a priority area. And to that end, we actually did some specific trainings for Alaska Natives. So I actually was out in Alaska a couple of months ago in some of the most remote parts of their state, doing some listening sessions, trying to understand the needs specifically of not only rural states, but also of our Indigenous folks as well. So, stay tuned for more information on that. But in terms of the current data, I would say that there isn't anything specific. And if there are, they're pretty outdated at this point.
Okay. The next question is, are you able to share the SBIRT scripting? But that's found within the tool itself, is it not?
That's exactly right. Yep.
Okay, so they just can go to the NCEED website, click on SBIRT, and it'll just start bringing them through it step by step, and they can see
actually,
the scripting.
Yes, and the direct hyperlink to SBIRT for eating disorders is also in this presentation. It's eatingdisorderscreener.org, so that'll bring you right to the tool itself. So that's also embedded in the presentation and free to access.
Wonderful. Another question is, are these eating disorders based in anxiety issues? What role does anxiety play?
I would say anxiety plays a really big role. I don't know that we are conclusively saying that these are always based in anxiety, but anxiety and depression are highly comorbid conditions when it comes to eating disorders. And that's anxiety disorders across the board, whether it's generalized anxiety, OCD, all those sorts of things actually tend to have a lot of overlap. Certainly, we do see a lot of anxious presentations, especially when it comes to eating feared foods or fear of weight gain, for example. So there's actually some evidence to suggest that one of the common treatments for anxiety exposure and response prevention can actually be used in eating disorders. So we can use that same sort of paradigm, the same treatment paradigm for treatment of eating disorders in many cases. Not all, but for many of those. So yeah, that's a wonderful question.
Okay, then we have one participant asking if we can share the QR code again, but that'll be in the slides that we put on our website, so they can find it there. Right. Is it on the NCEED website by chance?
No, because it's specific to this presentation in terms of what resources that we've curated, but it'll be in the slide deck.
Okay, great. And then Marie Black asks, people in the military are required to stay within weight limits. Are clinicians seeing a lot of eating disorders among service members?
The answer there is yes. That's my straightforward answer. It's challenging, though, in terms of us being able to collect some of those data, because I think there are a lot of demand characteristics about whether or not people feel comfortable disclosing eating disorder symptoms, especially as it may impact their ability to stay in active duty. That being said, there have been some limited studies knowing that this is a population that has increased risk. And that's true not just for the service member themselves, but also for their family members and also for veterans. Knowing that actually NCEED has developed some specific infographics and information about service members, families, and veterans when it comes to eating disorders, their increased risk for that. We're actually doing some specific trainings with the VAs and trying to make sure that the clinicians that are in those spaces have the information that they need. But yes, they're absolutely a vulnerable population.
And all of those resources would be available on your website, the training,
That's
the
exactly
extra
right.
materials, that sort of thing. So
That's
I'm
exactly
going to put that link at the end so that everybody sees them. But we have quite a few questions. I'm going to keep going. What telehealth services exist for those with eating disorders, particularly those in rural areas?
Yeah. So unfortunately, the answer to that is sort of state by state and sometimes even institution by institution. So, here in North Carolina, we offer all of our services through telehealth. We give people the option to either come in person or to do things virtually. Many patients have opted to stay virtual. I think it's just easier for a lot of folks. But what's true in this state may not necessarily be true where you are. That being said, we do know that the increased availability of telehealth services has dramatically improved our ability to reach more rural populations. Even here in this state where, our state is a mostly rural state, even though where I practice is much more metropolitan, we're able to reach folks that live 3 hours away and otherwise really would not be able to come in for regular treatment. So I would make sure to just sort of stay on top of whatever rules and regulations are coming down in your particular state. But as of right now, most states are offering telehealth services.
Okay, another question is there a way to share this information with a public school system?
Do you have any disorders? Yeah, absolutely. So if you have specific questions about what that might look like, I'd encourage you to reach out to me through email or send us something through our Contact Us form on the website, and we can talk about some of those specifics, but we have absolutely worked with schools.
Okay, Penny asks, were parents involved when you were creating the SBIRT tool?
Great question. They were not. Yeah, they
Okay.
were not for this particular iteration because this is meant to be provider facing. We do, however, have plans to develop a pediatric and adolescent version of SBIRT for eating disorders. And we do anticipate that parents will be heavily involved there because parents will probably have to be involved with some of those screening efforts. So yes, wonderful question.
Okay. And then Kristen asked, she thought maybe the audio had cut out for her. Could you mention again what validated measure this online screener was based on?
Sure.
And what age
It's called
range the screener is appropriate for?
Yes, it's called the SCOFF, and it's like it's an acronym. So each of the 5 questions is one of those letters, and it is validated for adults. So those 18 and older. So higher end of pediatrics, lower end of adults.
Okay, great. What are some ways that they may, eating disorders may manifest differently in different cultures? And does the tool compensate for these differences?
Yeah, so it's a good question, and one that I think we're still grappling with in the field. Frankly, part of the reason that we have this old stereotype about who's affected by eating disorders is because many times those are the folks that are recruited into clinical trials. Those are the folks that we have data on. Thankfully, there is a movement and a shift towards making sure that we're not only thinking about cultural adaptations for treatment, but making sure that we just have good estimates, a good understanding of eating disorders in other sort of non-majority populations, right? So what does an eating disorder look like if you are a young Black queer teenager, right? What does an eating disorder look like if you are not necessarily able-bodied? And I think that those are things that we're working on in terms of collecting the data. So if I'm transparent, I would say that the current SBIRT protocol is really built around an existing validated screener and a framework that we know was developed for use in a primary care setting. When it comes to making cultural adaptations, I think that's something that we're very open to doing. And in fact, one of our longer term plans is to actually work with some of the centers of excellence that SAMHSA has funded that focus specifically on some of these communities. So there is a center of excellence dedicated to behavioral health in African Americans, a center of excellence dedicated to behavioral health in the LGBTQ plus community. So to the extent that we can interface with some of those organizations and groups to make sure that what we're doing with this sort of first version becomes more culturally sensitive, we're absolutely open to doing that.
That sounds very dynamic. So we have a question from Christine. She says, as an occupation health nurse, I've been asked to speak with a new employee who has been observed not eating and very thin, a recent college graduate, and claims he or she has no time to cook. Any suggestions on how to maybe broach the subject?
Boy, that's tough. I think that especially in an occupational setting, the boundaries are just different, right? If you were friends or a family member, you can have a conversation that looks a little bit different. I guess what I would say is that if you're in a position where you have to do this as a part of your job, I would maybe just stick to observable, objective things that you're noting that have impact on this person's ability to engage meaningfully in their job tasks. So for example, if they're absent from the floor for extended periods of time, and the suspicion is that maybe they're, either binge eating or maybe they're, compensating for a binge eating episode in some other bathroom, I guess I would encourage you to not necessarily make guesses or hypotheses about what this person is doing, but to stick to objective behaviors that you're observing and to express concern. Listen, as your boss or your higher up, I'm concerned about what's happening. How can we help you be more effective in your role? Are there other sorts of resources that could be helpful for you if you're struggling in some way? So I know that's probably not terribly specific, but that's kind of what comes to mind for me in this moment.
Okay. And then Ashley asks, for behavioral health providers working in the primary care setting, do you recommend or can you recommend a more in-depth screener to help with a differential diagnosis between the different,
Yeah, so one of the things I would do is that if you're looking for differential diagnosis, that's a pretty nuanced piece. So I would actually just recommend that if they're in a primary care setting, getting them referred to specialty care. That way somebody like myself can do a more thorough assessment and get folks funneled towards the care that they need. That being said, there is a self-report measure that's commonly used in research studies that's sort of more transdiagnostic. It's called the Eating Disorder Examination Questionnaire. And there's actually a freely available version of it through the National Institute for Health. So if you go to the NIH website, or if you just Google search the Eating disorder examination questionnaire through the Phoenix toolkit. That should come up for you, and you'll have a free version there.
Okay, great. We're running out of time, so I'm just going to have one more. But if I have not answered your question, please reach out to Dr. Peat directly, and
Yes,
I'm
please
sure
do.
she'd be happy to answer any questions. Our last one will be from Cassandra. Are there instances where RX management, I guess prescription management, causes eating disorder or a side effect of this prescription management on appetite? And if it does that qualify as an eating disorder if it's sort of brought on through medication?
It's a great question. So it's part of the reason that we're really intentional with language, because anorexia nervosa is an eating disorder, but anorexia is simply a loss of appetite. And so probably what you're referring to here is that there are many medications that may actually result in anorexia, a loss of appetite, as either a side effect or as sort of part of this medication management. And so no, it technically wouldn't classify as an eating disorder unless there were some of these other cognitive and behavioral components. That being said, if the loss of appetite, the dietary restriction goes above and beyond what you might expect with this particular medication, or if it doesn't resolve in that sort of 4 to 6 week window where a lot of those side effects resolve, that might be a reason to make a specialty referral just to rule in or rule out a formal eating disorder diagnosis. Great question.
Terrific. Okay, so we've gotten to the end, and Gabriella, who's our host, I just want to say I can't get into the chat to put a link in for everybody. Is there a way you can open that up?
Feel free to shoot it over to me, and I'm happy to put it in the chat.
Okay, great. So I just want to leave everybody with put that in there. 3 different links. One, of course, is to NCEED, where Dr. Peat and her team are just doing this incredible work, where you can get a lot more training. They have training that you can get continuing education credits for. There's much more information on things that are going to be of interest to you and give you infographics and things to think about, and resources for an individual with an eating disorder, the family member, for the physician or healthcare worker. So we definitely want to get that in there. And then we also want to ask you guys to come visit our National Eating Disorders Awareness Week webpage on womenshealth.gov. We have lots of resources, a lot of things updated. We'll have the slides from this presentation on there, and we'll also have this recorded webinar. And lastly, we also gonna I put in a little link about 2 awards that we had given that Lieutenant Marshall talked about for eating disorders, just to give everybody a little bit more update on what's going on at the Office on Women's Health. So thank you to everyone who came and took time out of their day as we observe this Healthcare Eating Disorders Awareness Week. We all know how important it is, and as Dr. Peat was saying, how we have to just sort of broaden our idea of who is at risk for living with an eating disorder. So thank you, Dr. Peat, and thank you everyone for coming today.
Thanks, everybody. Take care.